COVID-19 coronavirus is destroying many lives around the world, including world leaders, and until now, there has been no cure. COVID-19 is tearing families apart. It has destroyed the economy of many nations and is separating people who are COVID-19 infected from their loved ones. Many of our friends and families are dying alone, a terrible death of respiratory failure. Something needs to be done now. This virus is rapidly spreading throughout the entire globe. Even the healthcare workers who are responsible to take care of patients are getting infected. There is no telling who will get COVID-19 next, even with safety precautions in place. Until now, there is no proven cure. Providers have been left helpless with no defined cure for their patients. NABN TV is here to talk to Dr. Maurice Anthony Ramirez and co-responder, nurse practitioner Allison Sakara. Okay, Dr. Ramirez, as a veteran, a former senior physician, federal government official, and a disaster medicine specialist who has traveled the world training people and institutions in response to bioterrorism, what is your take on COVID-19, the deadly virus, and its impact around the globe?
Well, Kristen, COVID-19 is an expected pandemic. If you look back in history, about every 100 years to 120 years, there is a worldwide illness. And this has been documented back into the 1500s. We've been preparing since after 9/11 for a pandemic to strike within the United States. We generally see these type of diseases begin in Asia, and they move generally eastward through Europe and then finally reaching our shores. But it's the jet age. And with transportation, with global transportation, a virus can hop a jet just as quickly as any individual, as any executive. And because of that, we've seen COVID-19 move throughout the world in a very fast rate. The faster a virus moves, the more people it's exposed to, the faster it can mutate. And as of this week, WHO is reporting 8 separate strains of the disease, which complicates treatment, it complicates diagnosis, and it complicates restarting economies, because now the question becomes, if you have one strain and recover, will you be immune to the next one that comes along 8 or 10 weeks or 20 weeks later?
Well, we've actually had an opportunity to discuss quite a bit with our fellow disaster responders across the globe. And so many of us are viewing this as the challenge of our generation. My grandparents lived through the Great Depression, and my great-grandparents lived through the Spanish flu. My great-uncles through World War I, World War II, Korean War. My father's era through the Vietnam War. And this is the challenge facing us as an international community. And how can we best survive this for each other and come out on the other side in a better place?
So a lot of people believe that coronavirus started in China, a country with a population of about 1.5 billion in late 2019. According to reports, approximately 81,000 were confirmed infected, 77,000 recovered, and 3,333 deaths were recorded in China, where the deadly virus COVID-19 originated from. Chinese government was able to stop the spread of the virus. Today, many Chinese are back to normal life, going about their businesses. Here in the United States, over 400,000 have been infected and over 13,000 deaths have been recorded from coronavirus. What has Chinese government done to contain the spread, and what has the United States government not done to stop the spread of death in the United States?
Well, Christine, the first thing you have to look at is the fact that the coronavirus began in the fish markets in Wuhan. The first official reports were in the first week of December 2019. However, there were sporadic reports in social media among physicians of an unusual type of pneumonia as early as October. But if you just start with December, and then you track the rise, the peak, and the fall in Yunnan province only, they had their disease under control in late March. 4 months later, 16 weeks. Here in the United States, we're only in week 4. I know it seems like it's been a very long time, particularly with social distancing, with stay-at-home orders in 41 of 50 states and 2 of 4 provinces. But we still are 12 weeks behind the Chinese. Now, yes, the Chinese had an incredibly aggressive quarantine. And there's a difference between social distancing and quarantine. And their quarantine was enforced by military and police. You were arrested if you weren't wearing a mask in public. There were even instances where people who would not stay in their homes, they welded their doors shut. But you can do that in a totalitarian state. And there were discussions of doing it in Italy. And there are ongoing discussions of doing it in France and Germany now, because people are not observing social distancing. The reality is that if you can keep 80% of the population home, regardless of whether it's a 1.5 billion population or it's only 330 million, if you can keep 80% home, the other 20% are going to represent your essential workers, your healthcare, grocers, truckers and transportation, people who bring the supplies that everybody else needs. But if you can keep them home, you can not only flatten the curve, but you can actually decrease the spread until all those mild cases that everyone is wondering about have had a chance to recover. You've slowed the mutation of the virus. You develop what is called herd immunity, where enough people have become immune because they've had the disease, that now they work as a buffer so that the virus cannot spread from person A to person X, because it has to go through all the other alphabet who are already immune. When that happens, you can restart an economy early. How much earlier? Well, depending on which version of the Reeves curve you like, the curve that tells us how a virus is going to behave in a population, it could be as much as 6 or 7 weeks earlier to restart an economy. But again, 80% of everybody has to stay home. In the United States, best estimates in the best states, in the best cities, we're only doing 50%. And that means that this virus is going to burn along for about 12 weeks to peak. Now, New York will reach its peak earlier than everybody else because New York has been doing this longer than everybody else. And places that haven't even started on that upward curve, they won't see their peak until mid to end of May, because they're going to have to follow the same curve everybody else does unless they get 80% of everybody to stay home. That's my recurring theme on that point, because that is what the Chinese ultimately achieved. And because they achieved that, they were able to shut down transmission until they had enough immune people to block it from moving forward. But don't be fooled. The Chinese are still enrolling patients in trials in the north and the south of their country. They didn't stop the virus. They didn't contain the virus. It was too late. What they did was they stopped one massive peak. They stopped their New York City. And now they're having to deal with it in the rest of their country.
Okay, so talking about healthcare workers' protection, many healthcare workers got infected with coronavirus, and some of them died while taking care of coronavirus patients. What do you think the government can do to protect the emergency medicine physicians, nurses, and healthcare workers working in the front line of the massive wave of patients sick with coronavirus?
Well, unfortunately, the government can't do a lot. The Strategic National Stockpile is a limited resource. And at this point, the number of masks for N95 style for healthcare that are remaining in the stockpile are being reserved for federal healthcare workers, people who have the same job that I used to have and who will deploy to places that are the next hotspots and will need personal protection themselves. That means now that we have to start getting more creative. We have to start being more proactive as individual providers, and we have to have the government tell large hospital corporations that are used to protecting their image that it's okay for me to bring my own PAPR, or for me to bring my own respirator, or for me to bring my own masks, or for me to wear a disposable poncho because there are no gowns left, and to not retaliate, because in the end, the person whose life is on the line now is that healthcare worker. When we work in the emergency room or any place in healthcare, we have this imaginary line. And on one side of the line are patients and illness. And on the other side of the invisible force field is me. And that feeling of invulnerability is what allows you, with your appropriate gowns and gloves and masks and goggles and face shields, to walk into a room with somebody who has measles or COVID-19 or tuberculosis and treat them empathetically as you would want them to treat you if you were on the other side of the line. But when you obliterate that line suddenly, you steal away my safety, you raise my blood pressure, you give me blinders, and it make it difficult for me as a healthcare provider to do my job. So the government can provide that protection so that the healthcare workers, and not just doctors, but more importantly, the nurses and the orderlies and the people who are cleaning the rooms between patients, can do whatever they have to do, whatever they can do, whatever they can find to provide for their own protection.
I guess I have a slightly different viewpoint, Maurice, that in my viewpoint, you just can't have enough protection in these sorts of environs. I think that we as a country, the government is ours and we are the government. We as a society are mandated at this point to work with our officials to provide all of the things that need to be provided, to give the support that needs to be given to our healthcare workers, to those who are supporting the healthcare workers, and to all those essential folks in whatever occupation that they are in, that they are letting us be able to take the trains to the hospitals, they take the buses to the hospitals, put food on our table for our families before we go to the hospitals. All of those things are critical, and all of them require the same level of protection. They're protecting themselves, they're protecting their families, their neighbors, their entire neighborhoods, and everyone that they encounter. Everyone who works at a mail order facility, putting together groceries, every box they touch, they are sharing what they may or may not have been exposed to with everyone who receives that box. And as a healthcare worker, every person that you encounter, you don't want to share anything that you have been exposed to with your next patient. Yes, we all need to protect against COVID-19, but COVID-19 also opens the door for many other opportunistic infections to follow in its wake. And you may be able to survive COVID-19, and then your challenge is a different type of pneumonia on top of that in the end, or something that you might normally be able to fend off, such as a condition that you live with, diabetes, hypertension, asthma, COPD, but your defenses are down and you are open to a whole host of complications as a result, whether you are, no matter which side of that N95 mask you're living.
Okay, so I understand that your company is working on a protocol for coronavirus. What can you tell us about that?
We're very lucky at the High Alert Institute. As a 501c3 not-for-profit, sometimes our research opportunities are limited by funding. But we have a great corporate partner in medical and regulatory affairs specialists. These are people who, for a living, do literature research. They look into the safety of medical devices and pharmaceuticals, and they help pharmaceutical companies and medical device companies obtain licensure worldwide. They understand what it takes to actually determine that a therapy or a drug regimen is successful. And that's been the problem with COVID-19. Everybody has their idea of what will work. And it's based in good science, the science of antiviral repurposing. It's a molecular biological science. But ultimately, you have to test things in a patient. And when you're dealing with a pandemic, you can't take half of the world and say, guess what? You guys are the controls. You're getting sugar pills. So you have to test real drug against real drug. And if you don't understand the math of how that works, you can very easily choose the wrong therapy. And if that happens at a national level, you can waste millions of doses, which are a resource that you don't get back. So drug stockpiles are used up if the wrong therapy is chosen. So the High Alert Institute, partnering with Medical and Regulatory Affairs, was asked to look at the whole of the scientific literature as it existed in the middle of March. That's 87,000 articles and abstracts. We're fortunate that Medical and Regulatory Affairs has the technology to screen and evaluate those articles without having to have them all read by people, although thousands were read. And they were able to calculate what is called an objective performance criteria, or OPC. It is a regulatory number that regulatory agencies like the FDA, like the European Union, like the Chinese FDA, can use to compare the outcomes of therapies in the real world and determine if they are statistically superior to this minimum success from the literature. If you are better than the literature, you're successful. If you're worse than the literature, you're a therapy that needs to go to the wayside. And now that that number is out there, agencies can start saying, this is a successful treatment. Now, along the way, one of the things they discovered is that very much like HIV and other complex viruses, you can't use a single drug. It just won't work. You're only interrupting the virus in one place, and the virus will go around the drug. But if you interrupt the virus's life cycle in multiple places, 3 or more, you are statistically superior to single drug therapy. That means that interrupting with more than one drug will work, sometimes even with drugs that failed by themselves.